This session is truth telling. We're going to talk from the field as frontline workers and as research coordinators who have been working over the past 3 years on a study that involves recruiting Black women living with HIV. And so, given some of the sobering statistics you all have heard this week, we wanted to talk about what some of those facilitators and barriers or challenges and what we like to call experiences, opportunities for improvement to recruit and retain Black women into research. I'm Danielle Campbell. I am a graduate student at UC San Diego. I'm also a clinical research manager on a project, a pilot project, an R34 funded project to look at the use of a mobile health app to improve HIV care outcomes among Black, cis, and trans women living with HIV. We got funded 3 years ago by the National Institutes of Mental Health. It was right before the start of the pandemic. So if you can imagine our joy and excitement and finally getting this freaking proposal funded, and then boom, COVID hits. So we had to reimagine our mobile health app project and how we were going to recruit women into it in the middle of a pandemic. So I'll talk briefly, but I wanted to take a moment to introduce my stellar colleague here.
Thanks, Danielle. My name is Wanda London, and I also work at UCSD, and I am one of the peer navigators that went into the field and was actually work with the ladies in retaining them back into care with our project.
Thanks, Wanda. So I think with that, we can go ahead and jump right into it. So our study, as I mentioned, is an R34 funded project. And we were funded by the National Institutes of Mental Health, again, at the start of the COVID pandemic, literally like maybe 2 months before it started. So our project is entitled Link Positively, a trauma-informed, culturally tailored web app to support HIV care engagement in Black, cis, and trans women living with HIV in the US, or I'm sorry, in California. And then we recently decided to expand our recruitment pool to the state of Oklahoma. Oklahoma is one of the 7 designated rural states that is on the cusp of an increased rate of new HIV diagnoses. And so given that there's a dearth of research happening in that area, we had a relationship with a community-based organization, so we thought, why not expand our reach into other populations that are non-urban based to help support their HIV care-related outcomes anyway. They're just as awful as women in urban areas, and there's a dearth of resources. So sort of maximizing the potential for greater good. So as you've heard all throughout this conference, not all women are equally impacted by HIV. Black women specifically accounted for a little over half, so about 55% of the new diagnoses in this country, which is, should be sending you all into some sort of tizzy because we don't comprise nearly this number of people throughout the whole US. So such a small number of us constitute such a large number of new HIV diagnoses. So there are so many barriers to engagement in care among Black women. So based upon some focus group discussions that we've had, and I'll let Wanda elaborate a little bit more, violence, substance use, adverse mental health, stigma, housing instability, poverty, food insecurity, access to care, incarceration, lack of or limited health insurance, residential segregation, discrimination, medical mistrust. These are some of the barriers to engagement in HIV care among Black women that we've identified. Are there others that you all can think of that are not on this list? Any other barriers to engagement in care among Black women that you don't see on this list? Transportation, got it. Others? I'm taking notes. Religious beliefs. I heard others. Y'all got to speak up. Child care, elder care. Oh, that's a good one. I've heard that. Lack of support. Thank you. What was that? Lack of information. Oh, okay. Lack of representation. The messenger matters, and so does the receiver. Wow, that's a really good one. Pharmaceutical or pharmacy? Okay, thank you. Yep, we've been hearing a lot of that on the heels of COVID. When you throw in conversations about provider burnout post COVID, folks are moving out and moving into more lucrative spaces. Thank you for that. So the goal of Link Positively is twofold. We started off by wanting to develop this mobile health app, right? The task was clear. We got to put care back into the hands of people living with HIV and define care in paradigms around that definition that support their engagement in care. So we started off with focus groups to help us develop and test the Link Positively app. And as I said, it's designed to support sustained engagement and care among Black women living with HIV. If you all know anything about the HIV care continuum, Black women experience the worst health outcomes amongst any other population of people affected by HIV. So we are not retaining care, we are not engaging in care, and we are not virally suppressed. So folks are not taking their meds for a myriad of reasons that we'll go on to define as part of this research. So our partners, Wanda and I represent UC San Diego, as well as San Diego State University. I'm also on the faculty at Charles R. Drew University of Medicine and Science, the only HBCU in the West. Our partners in Northern California, World, or Women Organized, to respond to life-threatening diseases, and Guiding Right in Oklahoma. So we're in San Diego County, Los Angeles County, Alameda, Oklahoma County, and Tulsa, all regions of the U.S. where the burden of HIV is high in women and the lack of service utilization is also high. Yes, ma'am.
Your three partners, the first three there are all academic institutions, and the other two look to be community-based organizations.
That's correct.
Do your top three, the first three listed, excuse me.
Okay.
Do they have clinics? Are they out in the community, or are they more research-based?
No, so all of the three. So we're on the faculty. We're also part of the street outreach team. We conduct the research in real time. So we're not just academics in the tower. We're also on the front line doing the work. Wanda mentioned that she works with the peers. So it's a little bit of both. I know it may be scary that the top three academic partners, the three partners listed there are academic institutions. However, like at Charles Drew University specifically, the Oasis Clinic is the longest freestanding HIV clinic that was developed in 1981 by Dr. Wilbur Jordan. And so we have a direct relationship with that clinic, and they serve as a repository of referrals for participants in our study. So when you talk about women who are not engaged in care, having that academic/clinical partner as a direct pipeline to get women into care minimizes that burden. So it's strategic, we promise. And as we said, our population of focus is Black women living with HIV who have experienced interpersonal violence, not including adverse childhood sexual experience. So here's the aim. Aim one, we wanted to develop Link Positively with input from Black women living with HIV, peer navigators, and providers who are represented in the San Diego Center for AIDS Research and the Health Equity Community Advisory Board. So we started off with some usability testing and beta testing by Black women living with living with HIV who were affected by these three comorbid conditions. And so Wanda, you want to talk a little bit about the focus groups?
Thank you. Yeah, our focus group started out, and at first, initially, we were at the ARC, and you asked part of the facilities. Well, one of the clinics where UCSD is on clinic, and that's where we got a lot of our ladies from to come to the focus group. And we were at the ARC in Hillcrest, and the initial focus group was just to see if there were going to be an interest in the ladies attending, working with the website. And they selected what they thought would be beneficial and what they thought they would benefit them, because that was our concern. A lot of these ladies were not techno, wasn't able to use technology. So that was the big thing, was are they going to be able to use the web once we got the site, once we got it set up. And so that was our first focus group. Then our second focus group was after they, developed some tools and the IT was able to bring out, and Danielle and them were able to present to the ladies what they did in the last one. Then we went from there to see how this is going to work. If we, we put the tips in there, and I know Danielle's going to explain all that, but I'm not going to touch it, I promise you.
That's okay. Go for it. Go for it.
But we wanted to know what the ladies were going to work with and what they felt comfortable in working with. So that was part of why we were having the focus groups.
So, Wanda, you want to talk briefly about it?
Was that your question? No, that was the end of it? Thank you, because Danielle is our recruiter. No. How we got the focus group started was we went to 3 clinics, okay? We went to...
In the San Diego area.
in the SoCal and San Diego area, that's true. Owens Clinic, we did a, Christie Place is not a clinic, but it's an ASO. So we got ladies from Christie Place, we got ladies from Family Health, and I believe we even had a couple ladies from San Ysidro. Yeah. Okay, and they came to our facilities in Hillcrest, and that's how we started out with our focus group. And you know what? We fed them. We got them there because you have to get their attention. And so we offered I think we even paid for babysitting that time. So
So all of the structural barriers that you
Yeah.
all identified, the childcare, the food, and we hosted the focus groups in local context. So Christie's Place, to what Wanda was saying, is one of the only
Yes.
and oldest ASOs or AIDS service organizations that are focused on women in the San Diego, California area. So we hosted it in a place where women are familiar with accessing their ancillary care services. So we brought food, we, set the scene, we provided really nice incentives to get folks there.
in the bottom line, we made them comfortable. I'm sorry. We made them comfortable, and that's one thing. Ladies need to feel comfortable in an environment where they feel they can share, okay, whatever it is. And if we're going to talk about HIV, and like we were asking them, there were a lot of concerns like, is this going to be private? Will someone know about this? So we had to make sure that our ladies were comfortable in participating in what we were doing. So that's how we got them out there.
Yeah.
Several.
We had several.
In the SoCal.
No, we were strategic in engaging our partners. So we had some academic institutions, we had ASOs, we had, we worked with a network of key opinion leaders in communities. So women who organize, not unofficial, but support groups that are not attached to an organization. Like there's a focus group, there's a support group of women that have been organizing for about 30 years with women, and we got the word out. We work with, as I said, key opinion leaders, and we really just got a sense of which organizations would be able to provide the best support to us and getting the word out to women.
I think of them as our gatekeepers.
Yes.
Our gatekeepers.
Hi. Of course. So LA is part of the encatchment area, as part of this study. Uh-huh. Can you tell us a little bit about what WISE is? I need you on the mic because we can't. Can you pass her that one, Wanda, so you can hold on to yours?
Yeah, I got it.
And if you could say your name
I'm coming to you. Yeah.
and where you're from. I think I know you, but I didn't plan her, I promise.
I know. Hi, my name is Leith Connolly, and they call me Nosy. So you guys could call me Nosy, it'll be easier. But I'm with the LA Los Angeles County Commissions on HIV, so that's where I know you from, Daniel. But the WISE study, my God, it was the Women HIV
Women's
interagency study. Now, this study I mean, it was it was on the East Coast and the West Coast. I got into it in my early diagnosis in 1990. I was diagnosed. I was looking to find something other than AZT to help me to deal and cope as I'm learning about HIV and AIDS. So I was 23 years old. So I met Wilbur Jordan. That was the first doctor I went to, and from there, the TH Clinic. And that's where I got into the study on the USC. The study looked at the virus, how it works in women, that's positive and negative, how it affects us, the different things that, affect us, even the medications, because as we know, the medications back then, we only had AZT. So I got into a lot of different studies, research studies on medications. Also, it was looking at how the medications, as we're, advancing in the medications, how is it affecting us as women? Because our composition for men are different. So it was a whole lot of, it was so intense. And I was so sad because that study went on for 20 years. And I was in it for just about all of those years. And in that study, going to USC and Charles Drew and getting the medications, not only that, they caught early cancer of my body, and they were able to turn that around, And so the studies, for me, is very important because with those studies, they could, they come up with new breakthroughs, with new medications, with new, with new RTAs, with new regimens that could really help us, especially as women, because we are affected differently, and even women as opposed to HIV negative women, we're all affected differently. And I would like to see a study done, because I'm going through menopause, and I'm having a hard time, okay? And I just
Hold
need a
that thought.
study.
Hold that thought. I'm also on the community advisory board of the UCLA Care Center, and there is a study on menopause. I promise.
Girl, I told you
I'll
I
link you
talk
to
you.
it. I'll link you to it. Questions? I saw some hands. We'll start here, then here. Other hands? Okay. What do y'all figure it out? Please, because we need to get it captured. Yeah. We've been warned.
Thank you so much for mentioning the WISE. My name is Joanna Rowe. I actually work at the Unite, and we fund the WISE.
We are on a protocol together.
And we
Stomp.
okay, we'll talk after.
Yes.
We will talk.
Yes.
First of all, thank you all for being here. Thank you for highlighting the issues, because it just continues to amaze me, being 49, 50% of the population, and the funded entities, clinical enterprises, clinical research enterprises, 20% of the enrollment, 20% is
Preaching to my heart.
I've been involved initially with clinical trials, so the interventions work, like the next generation of therapies, now to more social behavioral work. And the WISE is an example of a non-interventional study, but highly linked in getting women connected to care and revealing data about women's health that's ongoing. And most importantly, why it's been able to continue is because it has a control group. What's happening in positive women, we compare it to a negative control group. A lot of research entities do not have that really critical group, because it matters to the publications and getting the data out there to drive decision-making, drive the guidelines. And so, and it wouldn't happen without active participation, trust in the researchers, which takes time to build.
Absolutely.
Which I commend the WISE in being able to do that. And also, it's a complement to the interventional, the clinical trials, finding the next, whatever's going to go in that toolbox.
For treatment
It's
and
important
prevention.
for treatment and prevention.
And now cure.
Yes, but there are plenty of other elements, context, and all the other things that are part of women's lives. The lived experiences are important. And a study like the WISE that's asking questions about so many areas of science is critical. But it wouldn't happen without participation in a forum such as meetings like this, highlighting how to continue to be better at it. And so,
Which is
the
essentially
WISE
what we what the purpose of this workshop is.
Yeah.
To find best practices.
Yep.
To identify, opportunities for improvements to better serve Black women through the research mechanism. That is why we are gathered here today.
Yep. And
Go
the
ahead.
lines does continue. So I need to talk to you. It's been joined, and we can talk about, it was joined about in 2019. It's called the Combined Cohort Study. So we're learning about men and women's
So the
experience.
Y's and the Max.
Long term. It's a study of aging outcomes, and menopause is very important. So thank you so much. And
Of course. Oh, if you could give it back to.
I'm also drug resist, have a drug resistance strain, so they found that out. Got me, fast forward, they got me on the right meds.
To the lady with the bun.
she said she was with me.
Oh, she had her hand up. She was very sweet. Oh, wow. Okay. Anybody else with a hand up? Oh, the app. Okay, we're coming. I promise. We just wanted to get through it. Okay, so after we have the focus groups. Oh. Yes. You want to take her a mic?
Can you repeat? We can't really hear what,
She's going to bring you a mic, friend.
hear what you're saying, so, and I think everyone will hear, because that is a good question.
Thank you. I was just wondering, how'd you come up with your number, if it was a financial incentive to the participants? Because sometimes we hear pushback like you don't want to be coercive, but you want
Who are you
to
hearing the
honor.
feedback from?
Might be
Tell
my
us.
institution, but
A specific entity within that institution?
possibly. Yeah.
Okay.
So I wonder, like, what's the language being used? Because I did find articles to like support certain things, but you still hear like, oh, it's an arbitrary number. This could be coercive. Yeah.
Well, I have several thoughts on that. So the research around quantifying what's acceptable or not in terms of incentive payments to participants is still ongoing. Like there's actually a team of folks who are now starting to explore what that looks like. And within research networks, there are subcommittees of folks who are also exploring this question because institutional review boards will push back and tell us if you give people living with HIV $50, that can be perceived as coercive. They may be joining your study. I see your hand. They may be joining your study solely for the benefit of receiving that incentive. But then from a community perspective, you have to compensate people appropriately for their time and expertise. So giving somebody $10 and a Metro card and a sandwich, in your opinion or your institutional review board's opinion, and what the community is telling you is not the same. So we provided a $50 either cash or gift card to participate in that focus group. Based upon feedback that we got from participants about what acceptable compensation looks like. Of course.
I know you have a question, Tony.
Oh, it's not a question. I was just gonna respond to you because I just completed my research with my university, and the IRB was pretty much in agreement that $25 per hour roughly would be sufficient for compensation. However, the way you would word it is you wouldn't advertise it on the front end per se, because it would look like as if you were trying to convince them financially to be a part of it. So you would say after the fact that you were providing them with a gift card as a token of your appreciation for their time and effort.
Yes.
So that's what the research would say.
See your hand. Would you mind passing the mic? So they can get you on the camera.
So I'm not going to use the word research because I work for a federal agency where
And your name is?
my name is Corliss Heath. I work for HRSA, and we fund we fund projects, but we don't fund research. So let me say that. So we fund projects, we fund initiatives, we fund intervention initiatives for treatment and care, but we don't fund research. Okay.
Yes.
Excuse me. Now, in that, I lead the Black Women's First Initiative, so I am very much aware that you can, and with that stipulations there, I mean, you can give incentives. We don't have those stipulations around incentives because we believe in meaningful involvement of people with HIV. We encourage community advisory boards for individuals, and that's not just individuals showing up at the table so that we can say someone with HIV was there, but that's meaningful involvement that is from the decision making to the implementation
That's correct.
of the interventions. That means staff on the intervention, staff on the initiatives. So, and that's staff at the top at all levels. So that means individuals who are actually getting salaries. So that's more than just a gift card,
Say it,
and so
Corliss.
forth. And so there are so many different levels in terms of making sure individuals who are living with HIV and are compensated and have meaningful involvement. And I'll stop right there because I probably have something else to say.
If you want to, before you hand the mic, can you tell us a little bit about the Black First Ladies Initiative?
The Black Women's First Initiative,
Yes.
and so people have already heard my mouth over the past couple of days.
I haven't.
About the Black Women's First Initiative. The Black Women's First Initiative, and that's what we have coined it. The official name is Improving Care and Treatment for Black Women Living with HIV. That's the official HRSA name, but we coined it the Black Women's First Initiative because it actually is the first initiative for Black women that any federal agency has funded.
Ever?
Ever.
Why is that important, Corliss, in 2023?
It is so important because Black women have been left out, overlooked, underserved, all of that. And so for in 2023, and the initiative was for, in terms of implementation, 3 years. We still have 1 more year for the evaluation and technical assistant provider, where we will be disseminating. We have a journal supplement coming up. We have the implementation manuals that will be coming out. Andrea here is the evaluator for one of our sites that was in Chicago, but excuse me, we have 12 dissemination sites from the East Coast to the West Coast. One of our sites was at University UCSF. Yeah, so one of our sites was at
Northern
UCSF.
California.
Right. So from the East Coast to the West Coast, but really just focusing specifically on Black women. And we had one of the sites in Atlanta that was a mobile app. That's why I was like, I want to get to the app. So
Wait, who'd you work with in Atlanta?
Grady had the app.
Okay.
So Grady had the mobile app. So
We'll see what our app and their app is doing. How about that? Our app is apping. Okay. Question? Comment? No. Of course. Thank you for being our Vanna Black, madam. Appreciate
Also, I wanted to know because I was in that Y study. And I know the importance of studies. That's not the only one, but that was the longest running one that I was in. I have been in studies after study. I just finished the study with Reprieve. You guys know about Reprieve.
Absolutely. Results are out,
Yep,
published in the New
results are out,
England
so they
Journal of
ended it-
Medicine.
They just ended it recently,
Yes.
and they said, yep, they were looking at maybe it was going to be longer, but they got the results and everything. I would like to know, how can I get the fullness of the results? Like, where do I get that from? Like, after we do these studies, I would like to know, like, how do we get the results of, of what from the study, the actions that resulted, or you know what I mean, like the outcome from us participating. Because I think with that piece, I'm an advocate, but I'm also on a planning council. But I think with that piece, if we have that and we take it and let people know, hey, this is, the clients that we see, the people that we advocate for, we say, hey, this is an important part, and we know that, I think that that would help us to get more black women. And because I think, you know what I mean, like, you have to, like, hey, this is really important, and this will, and that's why I got involved. And since that one, I'm telling you, it has blessed me tremendously. So I would like to know, like, how we get those reports.
Absolutely. So in another life, I'm on the Community Scientific Subcommittee for the AIDS Clinical Trials Group, and we work with the investigators who conduct studies like those to make sure that there's a continuous flow of exchange of information, particularly the results from the studies that get to the communities of people who participate. So I've taken a note here, and I will follow up with your protocol rep who is from the community to make sure you get them. So in keeping on with the focus of today's conversation, we'll walk you through our study, and then we'll go back to hear some testimonials from folks who have either participated in or supported our work. So here is what, in part 2 of our study, what we aim to do. So we had the focus groups. We heard from Positive Women about what they wanted to see in an app. We developed the app with an external company, and then based upon the feedback that we got from women, in AIM 2, we pilot tested the app. We wanted to assess the feasibility and acceptability and preliminary effect of the app on women's ability to maintain sustained engagement in HIV-related care. How we did that? We looked at some care markers. So, some of the benefits of the app: it's culturally tailored, it's gender responsive, it's endemic responsive. We, as part of the other co-occurring conditions as part of our study, we looked at substance use, adverse mental health outcome, as I talked about at the top of the discussion. And so here's some preliminary activities on what we've done. We've had one focus group among Black women living with HIV. We also conducted a focus group among Black women living with HIV who had experiences as working as peer navigators or in other supportive capacities for Black women. And then since the inception of the study, the process has been very iterative. So based upon real-time feedback that we receive from participants, we can then revise and refine the app as needed. So we're in the beta testing phase, and our pilot study seeks to enroll 80 participants between the jurisdictions in California that I mentioned and Oklahoma, in Tulsa and Oklahoma counties specifically. So now to the app, Ms. Corliss. Major components of the Link Positively web app are here on the screen. So Wanda talked about these educational and self-care tips. This is what we mean by whole person care, right? We started with these educational and self-care tips. This addresses some of the mental health aspects. So it's a searchable database that's embedded within the app, where women can look for information around topics that are related to being a woman living with HIV. So condoms and STIs, violence prevention and safety planning, exercise, mental health, stigma. Then there's a social networking component. So think about Facebook or Instagram. So you can customize your profile. You can create your virtual avatar, upload a picture, whatever works best for you, so that you can then interact on the platform in a private and close community of other Black women living with HIV. So when you log into the app, you have a wall, just like Facebook. And on that wall, you can see posts from other Black women living with HIV. So you can post and update your status, you can post and update pictures, you can respond to other posts from participants, and then all throughout these interactions that participants are having with one another, you have a safeguard in place. Myself and other members of the staff are monitoring the posts for safety and appropriateness, cohesiveness, so that there's a minimal conflict. There's a minimizing of, adverse posts or harmful language, stigmatizing language. We actively monitor the site. So one of the really cool components that has gone over really well with participants is the resource locator. So participants can enable the GPS feature on their phone and search for agencies. So not only hospitals, clinics, food banks, grocery stores. We have a pretty comprehensive list of organizations that are included in that resource locator. All a participant has to do is enable the GPS feature of their phone, put in the zip code, or allow the GPS feature to be active if they don't want to, and then a search using a key term for an entity, and then it'll bring up all of the entities under that search feature. That's within 10, 20, 50, or 100 miles, depending upon the participant's preference. So it's like Google, but again, like Google, but embedded within the app itself. So as you pull up the different information about the community-based organizations, we have information that includes what type of services the entity offers, hours of operation, contact information, what types of insurance they accept, and at the time, if there were any COVID-19 related precautions. Any questions? Yes.
How do you keep them engaged?
That's coming. All right, it's coming. Spoiler alert. So because our app primarily, one of our outcomes associated with participation in the study is art adherence, we have a feature where they can self-monitor their own adherence. So we call it the M&Ms, or moods and meds. So every day a participant is responsible for logging into that app, using the feature of the app where they share their mood, and then they indicate whether or not they've taken their meds for the day. So there's also the reminder system that's built into it, where we can set up a daily reminder via text within the app, or a text to your cell phone. So it's really cool, if I wouldn't say so myself. It is cool. It's really cool.
Kind of nice working with it. It is. It's really nice.
So some additional features of the app itself, other safety components that are built into it. There's a minimalist design login page that I'll show you all. So you can, on the login page of the app, it's just a silhouette of a woman. There's no title listed. Women felt that it would be an invasion of their privacy, or if they weren't out with their self-disclosure or with their status, it was self-disclose, or it would disclose to other people who may have access to their phone what their status was. So one of the recommendations was that we remove it and then just use the silhouette. Access to Link Positively is by invitation only, so you can't search for it on your Play Store. You have to receive an individual invitation to log into the app. And then let's say you want to toggle from screen to screen, you want to send a text message or take a call, the app will automatically log you out. So you have to log back in order to access it. So let's say if your kid was using your phone, watching, YouTube, then they wouldn't accidentally be in your phone and post to your wall and Link Positively. The app automatically closes. And because we had context of violence to consider, we also wanted to make sure, again, that other folks who are not part of our community would not have access to the app. So on to the engagement piece to your question. That's where the peer navigators come in. So the peer navigators connect via the app with participants to complete a 5-session trauma-informed curriculum. That's the virtual coaching component, and it's, again, seamlessly integrated through the app. So you log into the app, there's a feature where you can access Zoom via the app and connect directly to your peer navigator. Your peer navigators also post and engage on the wall. So there's that continuous cycle of engagement that keep women engaged with the app, out of isolation, and into spaces where they can share lived experiences with other Black women living with HIV. So it gives space for those truthful conversations in a way that is appropriate for Black women living with HIV. So you can send text messages to your peer navigators within the app and to other participants also within the app. And it includes a gamification feature. So if you've ever played any online game, the more points you score, you unlock different features of the game. Link Positively is constructed in the same way. So the more interactions participants have with the app, they can level up, unlock different features, unlock different avatar icons. And here is a picture of what it looks like. So the first screen, when you click on the app, there's no Link Positively or login name or email address. It's just her silhouette. So once the silhouette pops up, you tap the screen, and then you're prompted to enter your login information and password. Once you log in, here's a screenshot of what it looks like to set up your profile. There are descriptors associated with your profile that you can attach to your profile to give people a snapshot of who you are. You can even post some language or some text associated with your avatar to give people a snapshot of who you are. So not only an image, but a brief, maybe 150, 160 character descriptor. So the third image to my right, your left, is the personal tracker. This is how we support medication adherence and viral suppression. Folks can complete this tracker to remind themselves to take their meds. The first thing, did you take your meds today? Yes or no? How are you feeling today? You go ahead and you click on the day of the week, and the little smiley faces, if you've ever seen the pain scale, come up. And using that sort of pain scale-ish type imagery, you can tell us how you're feeling. Okay? Over one more little box, the resource locator. So you type in the zip code, you tell the app within how far distance you want to search for an app. You can include a search, what do you call it? A search, yes, the search radius and a keyword. Jeez, I couldn't remember keyword. Dag. And then so it'll give the app some focused search features. And so like here, Planned Parenthood pops up. It tells the participant, a brief description. Planned Parenthood does X, Y, and Z. Visit their website here. Here are the hours of operation. Here's the phone number. Here's where it's located. Here's who you can contact, so that you don't have to thumb through countless number of websites on Google to find the information that you want to find. It's at your fingertips, and it's seamless. Any questions? Y'all can ask a question anytime. Don't want me to ask you. I'll start here.
It's just like you said, they're recording.
Okay. My name is Bonnie Harris, and I'm with Howard University.
Hi there.
I'm curious about, did you know how much the app was going to cost in your proposal?
Yes.
Oh, okay.
So we got different quotes based upon the proposed features. And then as the features changed and became more nuanced, depending upon that participant feedback, then the price may or may not change with it.
Yeah, my question is, how do I get an invitation?
Well, you got to be enrolled in the study first.
Oh, well, that's easy.
We'll talk offline.
Okay.
I'll come here, and then I saw a hand here, I think.
I've seen 3 hands
You remember who those hands are?
right here.
Two questions.
Yes.
If there's an interval that a participant hasn't engaged, will a peer navigator reach out? And then how do you determine that interval, not related to your protocol and your data collection schedule? And then my second question is, this is phenomenal. So what are you thinking for when the research is over and, you've informed, and would you be looking to look with your partner to improve this and roll it out, or those kind of questions?
Okay. So I'm going to take what I think was your first question. Okay. Go for it.
You'll be next. You'll be next.
Go ahead, answer your question.
Okay, so I can't remember the first question when you left. What was the first question?
If there's a lag, something could be going
Wanda could tell you that. Wanda has appeared. If there's ever a lapse in communication from your participant, how does it work?
Okay, there are several things that we do. We try to contact our participant and make sure, because sometimes, they really are kind of hesitant to being in the program. So we follow up with them and see, are they still interested in coming? And then we'll work with them. It could be the time. And, I've had several, and I'm going to say this, Danielle, as African American females, there's a lot going on in our lives sometimes. And we had several of our clients this last 3 months had death in their family, which set them back, so we had to work around that and still, try to do our study, but still be compassionate. So that's one way, just like Danielle said, we constantly keep them engaged. Another thing is you mentioned about if we see something on the web, if I'm looking at, like that's why Danielle said we constantly checking and we monitoring the app. If one of my clients, and we've had this happen, they're shouting for help on the app and we see it, well, we have therapists on staff. And so if there's someone that has a problem or they're reaching out, but they're not saying it, but I'm reading it and I could tell there's something going on here, then I'll reach out to one of my therapists and then in turn, we'll reach back. I might call them, reach to the client. I have their number. I'll ask her, is there anything I can do to help you? And do you mind if I forward your information to our therapist? So that's how we treat that.
So there really isn't. Thank you for that, Wanda, by the way. So there really is an iterative communication process. So folks aren't just in the app, taking the app. We supplemented that with the peer navigation model based upon the success of peer navigation in improving healthcare outcomes in Black women. So we translated into the HIV space. Corliss.
My
Ms.
question goes back again to engagement. How do you keep them engaged? Particularly, I know one of the things you talked about, technology. And so I'm going to go back to technology in terms of access to telephones, data plans, so forth, because you may have someone, I don't want no app. You're going to use up my data. You're going to use up my minutes. So why would I use an app? And who's going to pay for the phone? I don't have a phone.
Okay, so two things. You have to have access to a phone in order to participate in the study. That's one. Two, if women are limited in their data plans, we provide a technology stipend to help facilitate increased data while they're participating on the study.
Can I ask what's your stipend? Can I ask, you provide a technology stipend, how does that work?
So if a participant, let's say, has what they call an Obama phone, right? Obviously that data plan is going to be gone kind of quick. So we'll supplement payments to participants while they're on the study to expand that data. So
Are there any parameters around that?
not that I know of. When you say parameters, what additional parameters?
So
What'd you say, Ms.
so here's what I'm saying.
Tell me
So
what you
you
said.
asked what's the difference between so BeWow, the mobile app. So there are
And BWOW is from
Black women. Oh, wow, BeWow. On it. Black women. I can't even tell you
Okay,
what black.
tell us like-
but anyway,
Yeah.
that's the initiative at Grady. And so that's the bundled intervention with the mobile app, and so it is looking at mobile app and self-efficacy. And that's why I was asking in terms of, and I'm going to stand up, in terms of, because one of the things when we talk about barriers to care, because now what has happened, and I'm going to say this, what has happened, I don't want to say you. We have created another barrier to say if women don't have a phone, then they cannot participate. So that has created a barrier.
We certainly have.
Right. So what with our intervention, with the intervention at Grady, and I'll say our because it's a part of our initiative. With the intervention at Grady, if women don't have a phone, with the Grady initiative, they have community partnerships with Boost Mobile. So if women don't have a phone,
Boost Mobile's still around? What?
Yes.
No.
So they have a partnership with Booth Mobile. They will provide the women a phone.
I'm gonna Google that.
Right. So they will
Boost
provide the
Mobile.
women, they will provide the women a
Googling it.
phone, and the women have to engage a certain amount. They will have to engage a certain amount per month. And if they provide a certain amount per month, they pay for their phone, and they pay for their phone. They pay their phone bill up to they pay their phone bill, I guess, up to $50 a month. And if they already have, and they pay their phone bill. I think that's how it works. And if they already have a phone, then they have to engage a certain amount a month, and they supplement their phone bill up to $50 a month.
Okay.
So that takes care of that barrier, and you don't say that creates that. So one of the things that we have said, particularly among Black women, you don't want technology to be a barrier, particularly in this time of COVID, because a lot of your clinics closed down. Everyone was going to telehealth, and so if you're telling someone you can't come in, we want you to call in, we want you to have telehealth, then no, they weren't going to come, and they weren't going to use their minutes.
So I have a follow-up question for you. You said that the program supplements a stipend monthly for as long as they use a certain number of usage. Tell me what that is. How are you all monitoring it?
They monitor it just like you. So you have to go in, you have to engage. That's why I kept asking, how do you monitor engagement? So you have to engage. They set a limit of percentage. So a certain percentage per month.
Oh, it's
And
monitored
so
monthly.
right. So they engage a certain percentage per month. And as long as you engage a certain percentage per month, then you got your phone bill paid.
Okay. And in instances where participants are not engaging at that certain threshold, what happens to the stipend? Or let's
They
say,
didn't get their phone bill paid.
oh, so you pay directly to the phone bill or to the participant?
Oh, it went to you paid directly. The agreement was to Boost Mobile, so it went directly to Boost Mobile.
Okay.
Oh, BWOW stands for Black Women Organized for Wellness.
All right. Come on, be wow. Thank you. Other questions? I thought I saw another hand. I got it. Thank you, thank you, thank you. Okay. So just a bit of additional context on how the study is set up to work. Women are randomized 1-to-1 either to the standard of care or the intervention, which is linked positively plus peer navigation. Randomization occurs at baseline. Participants have access to the app for 6 months. Virtual peer navigation occurs via a series of one-on-one psychoeducation sessions. They happen for 6 weeks. And then there's the scheduled contact visits with the peer navigator over the course of the 6 months that participants are enrolled. So there's a baseline 3 and 6 month study visit. And then at each of those study visits, I do a 60-minute interview or administered survey. So we have measures that relate back to the study outcomes. So when you talk about mental health, intimate partner violence, adverse social circumstances, the effects of COVID on participation, and COVID-related PTSD. And then at baseline, participants are compensated $25 for completing that survey and $25 for a hair sample. So how we measure art adherence is not through a blood draw, it's through a hair sample. And that hair sample is shipped off to the UCSF Hair Sample Analysis Lab. And then that's how we can tell over time if the participant has been adherent to their meds. And then we can cross-reference that to what's listed in the app in terms of pull from the root. We clip down as close to the scalp as we can get. Yeah.
We can't hear you. I'm sorry.
Oh, yeah. So what's the efficacy between a hair sample and a blood sample, like the rate of being able to tell the detection of the the medicines within the system?
So there's been a bunch of research that's come out of Monica Gandhi's lab and other folks in using hair sample analysis to detect antiretroviral adherence in the hair. And it's also, I think, a much more user-friendly strategy versus trying to get folks into a clinic and then or into a blood draw lab. When you talk about transportation, when you talk about hours of operation, when you talk about the amount of resources that goes into that on the front end versus this other innovative method that's happening within the clinical research trials context, I think, it just really addresses some of the contextual limitations that we hear from participants all the time. The hair sample?
If they're on taking a medication.
I think it's 6 months, but I'll double check for you. Any other questions?
Yes, right here, she has one.
Is that the same thing as a genotyping? Is that, no, it's different?
It's from the blood.
It's blood, but it's not considered, okay. And then also with this is only during the participation of us being in the study.
That's correct.
So once we get all involved and this is, is working for a lot of women that are isolated, that don't go out but this has worked for them because they're on social media, so they know how to navigate this. This is easier for them. What happens then? Because I think that this is such a great thing, and I think that this is something that is needed, and that this should be the study right here. If this works, that this app works, that this app should be what goes on from
Well,
here on.
you're speaking our language.
And keeping us engaged and keeping us knowing about the support, the support that's available to us, and not having to just show up in person because of the stigma and, the other issues that we face as women. HIV is just another layer.
Indeed.
Yeah.
So I think that was the question of the young lady in the back on the red. So that's part of what we're doing first. So this study is going to roll out in several phases. Phase 1 is determining the feasibility and acceptability. We got to know first how Black women perceive it, want to use it or not. And then once we know if it's feasible and acceptable, then we can move into a larger scale clinical research trial where we test its implementation in real life and not in the context of just a clinical research trial. So we want to put it into community-based organizations, which is why in phase 1, we have them as our active partners so that they can best tell us how to integrate the app within their service delivery models. So we're designing the trials with participants in mind because they're part of the design team. It's not just a group of researchers saying, oh, this is a really awesome idea. Let's take it to women. It is not a Muhammad to the mountain type situation. We're going into communities, engaging folks and getting them to give us their most transparent and candid feedback about this app and this process.
I think, oh, I'm sorry.
Hi, me again. So 18 and older. We did not have an upper age limit. But what was the average? We did. So our average age of participant was 34 years old.
So moving forward, will there be any additional research regarding our aging population and utilization of these technologies?
I should hope so. That sounds like a sub-aim to me.
Hi, I'm Ebony Gordon from San Francisco. I had a question about the resource platform in the app. You mentioned before about having contact information. I'm wondering if that contact information is for a certain person, like if you have a partnership with a certain party in these organizations or what have you, to have a more seamless connection, I guess. They're trying to
So for like a warm handoff, so it's a little bit of both, right? Because California is so vast, and then we're also working with organizations in Oklahoma, we're limited in the amount of contact that we're able to maintain with those folks. So we have this resource list. Every number that's for every organization that's embedded in that app, I contacted. I was also the graduate student that put them in the spreadsheet that was sent over to the app developer to then be uploaded. So it's something that happens in real time, but we can't possibly maintain. There are over 4,000 organizations in California alone that are included in that app. So I don't have personal relationships with them all, but I can tell you I've contacted them all to understand if a participant were to enter their realm of services, where would they start? And then hopefully that's a way to get the participant through the door to a live person and then off to whatever other care associated consideration that they have. So it's not just saying, okay, boom, here's a resource for you. We do warm handoffs. So I'll get on the phone, contact somebody using that resource list that we developed in the app, and then facilitate that warm handoff so that there's that continuity of care. Just like Wanda said, we're like a family. We don't want to just send folks off into the nether saying, all right, holler back at us in a week. So we provide the warm handoff, and that's where the utility of the peers come in. The peers follow up with the participant to make sure that there was a follow-up in engagement and care or services based upon that warm referral.
I had another question.
Yes, ma'am.
About the social networking piece within the app. Did you find that any of your participants use that feature and if they got like a good deal of, vibes off of it?
So we have part of our studies we're collecting usability data. So we monitor how often participants are using the app. So to the point that you made, we have usability data. So we run reports and we can tell how long participants were logged into the app and which feature of the app they use the most. So we're going to categorize the data down to that granular level. Participant X logged into this feature for this amount of time. So we can correlate that and associate that into what, if participants actually use the app, and then we can look and compare that into whether or not they self-reported engagement and care. So taking it back to improving the care outcomes. So it's from the data to the engagement and services across these very carefully measured aspects of the app or components of the app. I'm not going to show that. I'm going to tell you about it because we're still conducting data. That's correct.
But one of the good parts about, if I can just share this
Of
about
course.
the app, about the ladies' engagement and talking back and forth. I always call it the Facebook of link positivity. I'm just sorry. But our ladies get on there, they share poems, they share stories, and like I said, they let us know how they feel. Like Danielle said, they're monitoring it. So it does have a lot of interaction with each other, and that's the positive thing. And as far as resources, I've had individuals come back to me and say, I went to this place and I found it on the app. And I'm like, whoa, okay.
That's the best part.
Yeah.
To know that women are really utilizing the features of the app as they were intended from the voices of other positive women who helped us from the beginning. So it's a full circle moment. It's the best part to know that women are receiving the information you're putting out in the way that they intended you to give it to them, not in what you thought was best. But yeah. Should be. That's correct. And not coming with a pre-compiled package and saying, what do you think about this? No, we came ground zero and said, here are some features of other apps that may have worked. What do you think should work for link positively? We do.
We're on it.
Miss Gail. I don't want to out you, Miss Gail, but Miss Gail.
That is because, on the back end, so what, as you're doing implementation, so one of the things that we look at HRSA is implementation assignments. So we're doing implementation. So even though on the front end, this is what I'm saying, so on the front end, you're saying, this is what we should look at
Which is next step.
Your continuous adaptation. So even though you've already implemented this, going back to your community advisory board, where your community advisory board says, yeah, this is good, but maybe you should also add this, or we may have thought, yeah, that was good at the beginning.
In theory.
Right. But we don't really like that. So we might need to change X, Y, Z, you know. So those are some of the things that, you just might want to think about, because these are some of the things that we did this with all of our initiatives, not just the app, but just with all of our initiatives, so you're, again, going back to your black women having the voice, you're giving them, not you as the researcher, but them having what I call the authoritative knowledge to say, this is what is important to us.
That's correct.
And empowering them to say, this is what we need for us to be healthy and whole.
So Wanda and I are both on the community advisory board, and then we have a community advisory board member in the space from our Oklahoma site. And we also collect that data at every follow-up interview. So we're covered in the community engagement aspects, and we're covered in that not only utilization, but that iterative process that I described at the beginning that happens at the follow-up interviews and in real time through the interactions with the peer navigators. So it's triadic, it's not just linear. So I wanted to share some COVID-19 related challenges and how we've had to adapt, right? It was a huge blow to how we were able to onboard participants, how we were able to onboard staff and really reach women. COVID just, I think you all would agree that it just rocked our lives. So how we've had to adapt the study in the context of COVID-19, we had to limit our in-person outreach, recruitment, and engagement with participants and staff at partnering agencies. So that's where the relationship building, to the point that was raised earlier, really happened. The phones were jumping, email inboxes were jumping, resource deliveries were jumping, because we had to know, right, compounding the already adverse mental health situations that folks were subjected to, how could we continue to provide not only the best milieu for the study to be successful, or even to be conducted, we still had a duty to provide adequate resources for referrals for participants who took time to join the study. So we had to deal with modified hours of operations at local CBOs, limited service provision at partnering agencies that placed a limitation on the referrals that we could offer to participants. It's not enough to provide a referral, but we also built in the mechanism of the follow-up aspects with not only the peer navigator, but myself as the clinical research manager following up with the peer navigator and the participant to see if the referral was completed. So we found through discussions that incentives amounts could be perceivably insufficient based upon the study time commitment. So to your point, IRBs may have said this was coercive, but that we had a direct feedback mechanism from participants to say, this is in fact not coercive. Participating in your study at this compensation rate is in fact rate limiting for me and my lived experience. So we had to take that information and that feedback right back to the institutional review board to let them know. And we had to rearrange our schedule of compensation for participants based upon that direct feedback. So it's that give and take. So they'll tell you, oh, this may be coercive. Guess what? Participants are saying that it's not. We need to do something a little different to meet the needs of the people who are telling us that this is insufficient. That's meaningful involvement. So I hear you when they say, oh, it's coercive. In fact, it's absolutely not. So here's what we did. So we had some recruitment challenges, and I asked you all at the beginning of you in the space, and I'll ask again. Your programs for Black women, how many of you experienced recruitment challenges? Lots of hands going up in the room. Talk to me about what some of those recruitment challenges were. You sighed. What were some of the recruitment challenges? Can you talk into the mic so they can get you on the Wanda, you got me?
Yeah, I got you.
Or Vanna Black. Thank you. Thank you, Vanna.
I'm gonna come down on the floor in a minute because I see
No,
several
no,
hands go up.
you can
You want to take it?
relax.
Get the other hands. Okay.
We have the only AIDS service organization in our region.
Which is?
Is actually we're in Indiana, and so that's the Gary, Maryville, the Lake County area of Indiana. And as long as we've been in existence, and we've been in existence for 28 years, women, our women are still our major challenge. I think a lot of it is still fear, the secrecy. And the secrecy is so bad that it even impacts their ability to even access care. And and even vital services that they are eligible for has nothing to do with their HIV, but they're just kind of just in a very dark place as far as not wanting anyone to know. And as much as we try, and we continue to try, I like some of these techniques that that you guys have used. This is my COO, Antoinette, Dr. Antoinette
Oh,
Cardenas.
doctor.
She's new, so I'm getting used to saying that. So a new doctor, Dr. Tony. But that is one of our major. We started out with women. Our agency started out with about 10 women who are all becoming diagnosed with AIDS. AIDS diagnosis all early on in the part of the AIDS epidemic, and those women, the safety was that they knew they were not alone. But now, as we advance, people it's differing in their connection. You know, a lot don't want to be connected, but they're comfortable with their case manager.
Yep.
But stepping outside of that, so I mean, if you have any advice on that piece of how to get women who really would, if they even got together, it'd be a good a combination of people being together. It's just getting them through that door.
Yep. Now, that group of women are who we hope to reach as part of the app, which is why, we can tell you straight from the field that those challenges are real because you have to overcome so much stigma, which is why the app has been transformed in that way. Women don't want to see HIV associated with the app. They don't want their partners to know, not only due to trauma and violence, but that stigma is real. So we've tried to be as culturally responsible as possible. And, participants know and they tell you through those follow-up conversations that we have. I'm sorry. Hi.
Hi.
Hello.
Hi. My name is Gail. I'm from Oklahoma City.
We got a couple. It's a couple out there. That's the same thing. They get
Why?
mad. They get mad. It's the whole group over there. Look. They get mad when you say it. I've been shaded.
And we have the carriages in Bricktown.
Yeah. Miss Gail.
But for me, as a woman living with HIV for 25 years, it's kind of hard to come out into the spotlight. I'm starting my own company. Where I'm from, it's a big stigma. It's a big stigma. You still get it's associated with drugs. It's associated with sex in yeah.
Come on, Miss Gail. You got it. You got it.
So it's not it's not something that it's kind of hard to wear it. What I've learned is through my experiences of it being given to me, I have to look at it as I don't want to give it to someone the way it was given to me. I wasn't asked permission, did I want this? So for me to, I know I don't want to be that kind of person. So these kind of events and to know that there is services out there trying to reach somebody like me. But I'm grandma. I'm an Amy. I'm the Amy. And I'm Gigi. So when you put HIV with, woo, that's some more weight for me to have to bear. And then to step out in the front light, for me, is saving my babies. But it's a big sacrifice to come out and let y'all see my face.
We're glad you're here, Ms. Gail.
Thank you.
Somebody behind
Behind you, Ms. Wanda.
you? Okay, here I come. I'm sorry. I know you're.
I think we missed some other people. Did I miss some other hands?
Right here.
Okay.
Hey y'all.
Hey.
So I'm Ashley. I am from Mobile, Alabama. So I asked a question about like the focus group. So the organization I work for, we're a non-traditional, we're not an ASO. We actually operate out of a rape crisis center, and we were awarded the EHE grant. So we've been trying to have focus groups and just to get people like to have the conversation about HIV and getting tested, but like we're having barriers because like they don't want to talk about it in Alabama. It's like it doesn't exist. Like a lot of people don't realize like obviously it's a lot of sex going on, but they still don't want to talk about HIV. So yeah, my question was like, but aside from incentives, like how do you get the people there?
Great question. So it's really about tapping into your networks, working with those community-based organizations that either, and I said community-based organization, not necessarily ASOs, CBOs that provide services to women, infectious disease clinics. They see women living with HIV. Establishing partnerships with the providers, who are my angels, case managers. You will not touch a participant patient without a case manager. Our case manager in Oklahoma is right there. Right there. You will not touch a patient, participant, however you want to describe them, until you meet with a case manager. Your therapists. These are folks who have direct hands on the participants that you want to have a conversation with. And if you're seeing that folks don't want to come in, pivot. Focus groups may not be in your future, but individual, semi-structured interviews may be. You can still analyze the data in a way where it's effective. And when you build that rapport, down the line, you can circle back to a focus group. But you got to start at the grassroots level. I can't stress it to you enough. Your network. Start with the folks who have boots on the ground. Your case manager is your angel. They will get you in touch with participants because they see them more than the nurses. They know, okay, let me look at my caseload and see who may benefit from participation in your study based upon your entry criteria. That's all. I'm going to say that with my whole chest. That's the way. Start with your frontline providers, case managers, peer navigators. That's the way. And if you want to talk offline, I'd be happy to help you with the resources that I have with the focus group questions that we use, semi-structured interview guides, the whole setup to get you off and running to have these conversations with people in your community. Go for it. You got me, Wanda?
I was going back to the barriers and the issues that we had. So my name is Iman. I work in, what's that? I stand it? Oh, oh,
I
really?
understand.
Okay, hi, my name is Iman, and I work in New Orleans, and so there's a few things I think when we were coming down to recruitment. One is New Orleans is big, but it's also small, and folks that you speak to are kind of tired of being researched and being asked questions again, and it goes back to the what happens, where does the research go, where do I see the results? So there's a bit of fatigue of people saying, I'm tired of you all asking me questions about this and this and this. And we also I worked for a CBO, and so then we had a partner, but that partnership didn't fully take itself all the way to the end. So then in recruitment, we thought we'd be working through this partner, but then it didn't happen as much. So we expanded in different networks, and then finally we put things online, but it was during COVID. So we got a lot of scammers actually for our focus groups because we put out the incentive. And then we realized, and it was supposed to be US-based, Southern-based, New Orleans-based. I started looking at, because people just weren't saying anything, because we also didn't want for confidentiality to say to put on your camera, because in case there are other people on there, we don't want to make you have to put on your camera. But then we were seeing their IP addresses were in different countries.
Yeah.
And so there were a bunch of different challenges that kept coming up, and really what we started doing was going and sitting in clinics, talking to providers, finding providers that we have relationships with and saying, hey, can we come and just hang out, have a space? You can give people a heads up, and then we can talk to people in a side room, et cetera, et cetera. And especially in the South, New Orleans is a very in-person kind of place, so that's what worked a lot.
Thank you for sharing that. I think I definitely will +1 the sentiments that you provided about sitting in clinics. It builds that rapport with the providers who will give you access to the participants you want to get in front of. You got a relationship built. Hello, madam.
Hello,
How are you?
Danielle. Nice seeing you again. My name is Maya. I am the clinical case manager in Oklahoma and for Guiding Right. And our CEO is sitting right here. And I just want to state that the clients that I've dealt with when they come into my office, first and foremost, I get to know them, but I tell them a little bit about me to make them feel comfortable, because everyone that comes in my office is not the same lady, is not a mother. They always have something going on. So what I do is I give a little piece of what I have going on to they can relate to. And that's how I get them to come to anything I have going on. My communication, I'm like on them. Like I'm cousin, I'm auntie, I'm asked to be whatever, I'm gonna be that. So I don't really have any problems with any of my individuals that come and see me. And they're not just African-American women, they're all races. So young and old, because I know some of them may be broke. Some of them may have their electricity turned off. So they're giving me not only what they're going through as far as their status, but on a personal level too. Because I've been there, you know, I'm from the country. I've had my electric turned off at a point in my time. So, you know, I relate to a lot of what they have going on. And then when it's time for a focus group, I'm like, hey, let's get together. What we doing? Sipping paint? What we doing together? And once you do that, oh man, girl, did you know that Maya had such and such, such and such? And I'll invite a guest, bring a guest. It's almost like you're at church, fill a pew, kind of like bring your guest. But like, let's fill the support chairs right here or wherever we are. Let's fill this back table back here at this restaurant and let them know we're here kind of deal. So I make them feel comfortable when they come into my office. I also give them a fun fact. So let me know a little bit of something about you. I'm gonna tell you a little bit of something about me. So that gives them so much more room, because they'll open. Once they get to talking, they'll open. So anyone that needs assistance on how my technique is, I can help them, but I enjoy and I love what I do in Oklahoma.
Thanks, Maya.
Yes. I just want to touch base as I walk over here. As Tammy had mentioned, this is my former director from the Liveness Project of Northwest Indiana.
Really?
Yeah, but Tammy has a heart. But one thing that we did, we had a house. It was Fort Queens, Miss King House. And it was a queen house. And we were always like once a month, all the ladies would come over for lunch and brunch. And it was a lady that had the house. And she was like a cohort for our community. And we brought, like she was mentioning, we would bring the ladies together. They would have lunch and dinner. And then we would unite. And it was a time that ladies were dying. I hate to say, we were dying. You know, I was one of those early ones too. But it was the fact that I had shame. I was very scared because I was really young. I was like I was really young. So I wish I was young again. No, but there was a lot of stigma. Yeah, it was. And I'm from Gary, Indiana. Well, I'm from Hammond, Indiana, but it's right outside Gary. And if you know anything about that area, there was a lot of, racism. So you had that. You were dealing with that, and you were dealing with people that didn't want to say that they were impacted with this disease, but they were quick to say all about you. Right. So how I overcame, and I thank you, Tammy, Tammy said, write it down. Read, get informed, and write it down, because I wanted to know, how was I going to live with this disease? And that's what we need to share with all our ladies. You know, you're going to live. You're going to live, you're going to be empowered, and you're going to be able to move on in life. You know, it's just not a stage that you're at. You're going to move on. So that's what I learned, okay? And I thank Tammy for that.
Thanks for sharing, Wanda.
So a couple of things. First of all, the young lady from Mobile, I, you said you had an EHE grant. Who is that through? Okay, so contact your HRSA project officer. One of the things that we have found, particularly with working with HRSA initiatives, community health workers are your friends. Community health workers, those are the people, community health workers know everybody, and they are trusted allies, they're trusted allies, advocates in the community, and they are gatekeepers. And so you want to make sure we are learning. One of the things that we have learned is that community health workers can get into places and reach people that no one else can, you know, so that's one piece. Also, some of the other things, some of the lessons learned, some of our lessons learned through the Black Women's First Initiative. When we talk about being culturally responsive, you know, sometimes we say we want to hold a focus group. Language, how are you presenting? You know, what are you saying? I want to hold a focus group, but what message are you putting out? How are you presenting the information? Because language matters, particularly when we're talking about a stigmatizing, and I don't like the word disease, but because that's a stigma,
Condition.
you know. So if you want to say we're holding a focus group on HIV, nope, nobody's gonna come, you know. So you have to look at language. You have to look at how you present information.
And who is presenting it?
Who is presenting the information, all of that. It is so many different things that goes into advertisement, communication, representation, and so forth. Yes, we had well, I'll put it this way. The majority of our sites had recruitment problems because of COVID. Now, we had some sites that we were just like, okay, can y'all just stop? Just stop. I mean, they had no problem recruiting. But, you know, like I said, because of COVID, you know, yes, there were recruitment issues because, you know, they couldn't get into, like with Andrea's site, they had their initial population were women who were just as involved coming out of the correctional system. So and the jails shut down. Mm-hmm. So no, they could not. So, you know, they had to pivot and they had to change their priority population. You know, so, you know, sometimes you have to change your focus or so forth. But again, think about your messaging and so forth. And then as Ms. Maya was saying, think about the needs, because if you want somebody to come talk to you, you know, and they're trying to figure out how their light bill's gonna get paid, where they're gonna sleep, how the kids gonna get paid, they're like, okay, what can you do for me? Mm-hmm. When you take care of that, then they'll come and talk to you. Mm-hmm. Deal with that, and then we can have a conversation.
Right behind you.
I'm going to go to her first, and then I'm back.
Thank you, Wanda. Go for it.
Oh, yes. My question, because you guys was talking about focused studies, I haven't done one since years ago when I was working with the Black AIDS Institute with Phil Wilson.
Phil Wilson, you
Phil
got it.
Wilson. What I wanted to know is because now I'm an ordained minister and I'm trying to get, I have access to community leaders and organizations that's faith-based churches, and they want us in their community because it's a lot of women, and you know how it goes in the churches. I want to know, who do I talk to? Like, how do I, someone that can help me to put together like a focus study, so it is, and we could take it to some of the churches that has requested that we come in and start being there. But again, not come in with just HIV, but come in with health sources, health stuff that's affecting all of us. Because again, like I said, 33 years. I was 23 when I was diagnosed. It wasn't a lot. I got into advocacy, and we were activists then. I got into that because
Still are.
I needed to save my life, raise my daughter, and my mom just had a terminal illness just before I was diagnosed. I didn't have, but thank God I had a supportive family. But a lot of people don't have that. Some of the barriers, quickly, is because we come from a Christian background, a lot of us, and that's where the barrier is. So I want to be able to take it into the church and let them know that, hey, there's some people in here, and we need to like have a voice, because we can't pray the gay away. We can't pray, prayer works, but we have to have some action with that. So I just wanted to know. Yeah.
And I'll be right there, Dr. Tony.
Of course. Just chat with me offline.
Did you want to respond to that?
We're going to chat offline in the interest of time. Alabama, did you have another question? I saw you. You good? You good? Okay.
Hey.
Hello.
I'm Diane. I'm part of the Oklahoma family. I don't live there anymore, but they still include me, which is a blessing. So Theo, thank you. Danielle, thank you. Maya, thank you. Gail, thank you. I was diagnosed in 1993. I was 28. I got custody of my kids. I got reinstated with the state, found out I was HIV positive, and my grandmother died, all in 1 week.
God.
And my grandmother was my best friend. And when I reached out to my family, the shame, the shunning, my sister would say some ugly things like, "You're dying, I can't stand you." My mother I had a fork and a spoon that she bleached. I couldn't drink out, I had my own cup. And my husband infected me, knowingly infected me. And I stayed with this man because I felt like nobody else would want me. So when you say, like, how did we get the women to come out? There's so much shame, and you feel dirty. And people back then in the 90s, it was oh, she got the package, she got the monster, and I stayed clean for 9 years, and then I relapsed because whenever I would disclose it, I would get rejected. So I would get high. I get high, I don't have to tell you. And that was been my story from 2001 up until now. And I have 2.5 years clean now.
Congratulations.
I'm tired. I need to come forth and be that face because it's been 30 years, yo, and I'm still here. I'm still here. And I listened to those babies yesterday that was born with it, and
Wasn't it? It was just heart-wrenching.
I
to hear
remember
some of those stories.
back in the 90s when I would go to a support group and it'd only be 3 of us. Like I said, I met these women last year this time, And a year ago from September, and they have embraced me. She calls me, she texts me. You know what I mean?
What's up, Diane?
Yep. Maya, Maya, you need anything? You know, you need a ride? You know, just the love. But I just feel like there's so many women out there that is so afraid, like I was all these years, to stand up and say, my name is Diane and I'm HIV positive, you know, and just scared that someone is not going to love me or accept me. You know, we all want to be loved. We all need to be loved. But it's so people are just so ignorant. You know, I had a so-called friend in North Carolina who was putting notes on guys' cars that I was talking to saying, go get tested. She got HIV. And I'm like, why would you do that? Why would you try to hurt me like that? You know what I mean? Like, so right now I'm not dating. I'm dating me. I'm learning how to love me, you know, without the use of any type of substance. You know, God sent me to Oklahoma 2.5 years ago because he needed to set me apart. He needed to get me away. I was in Charlotte, North Carolina. I relapsed. For 1 whole year, I got high. And God covered me. You know, he covered me. But when I left Charlotte, I walked out that house. I left my clothes. I left the furniture. I got on the Greyhound. I was on that bus for 2 days, and I was sick. And when I got to Oklahoma and I went to the emergency room, I had COVID and pneumonia. One more hit, I would have died. So when I got to Oklahoma, it was just work on me. It's a place in Oklahoma called Homeless of Alliance. They are awesome. Guiding Right, awesome. Okay, I left Oklahoma and I just moved to Virginia. And it is the worst place ever. As far as case management and help, they will not help me. And I'm like, what is going on? This is not right. I know y'all have the funding, so what is going on? But I just want to say thank you again, Danielle, Theo, Maya. My Oklahoma family, I love y'all.
Thank you, ladies.
There was another question.
I
Did we
think,
miss
I
it?
think it was one here. Dr. Tony had a question.
Go for it.
Wanda, my colleague and support group co-leader. I just wanted to comment for you as far as bringing this into the space of the religious environment. I'm also a member of a church, a Baptist church, and thank God we have a progressive pastor who allows me to use the platform. So we developed what was called a professional healthcare ministry, which encompasses nurses in the congregation and social workers. So together we formed this entity, this ministry, where I definitely, because I've been working for Aliveness Project for going on 16 years now, I make that my platform to talk about topics about HIV and AIDS and how it impacts women and our congregation, which is predominantly African American. So you can use that space in the church, and you can work with your pastor and develop a ministry such as that. And we talk about other, health topics outside of HIV as well, but making sure that we highlight that sexual health and sexual wellness is just as important as talking about mammograms and breast cancer and diabetes, et cetera. So creating that space at church, forming your own ministry, is how you can use that as a platform. And then going back to your original comment about your focus groups too, we talked about in our agency, we're trying to reach our aging population that are negative. And to reach them sometimes it's hard because no one wants to hear HIV automatically on our flyer. So we changed the language. Sexual health and wellness is our topic when we go into the senior centers. We're trying to go into the nursing homes. And then we can, when we capture them there with coffee and donuts, because I just got
Any other incentives, or is just coffee and donuts?
Well, they like coffee and donuts
Okay.
at this particular place. But again, utilizing that space, we talk about sexual health and wellness, and then that encompasses everything, so that we're not just highlighting HIV and then people kind of, draw away. We want to bring them in because we do know that those that are aging are still having sex.
Oh, yeah.
Evidenced by the high syphilis and, chlamydia cases that are happening in our nursing home. So, my feedback.
Thank you.
Excuse us, people at 65 is still living.
Other comments or questions before we sort of, I'm not sure. If you had a question and it did get answered, just raise your hand. So we're in the data collection phase. We're about halfway through our study. We've had some successes and challenges to recruitment, but all in all, we're proud of where the study has come to and where we've come from, COVID aside. So just wanted to share some participant feedback. So folks liked using the app, and they described some of the best features like the medication and mood reminders. My most memorable experience with using the app was the connectedness to other women living with HIV. Overall, great app. Just take some time to build an online presence, and I know what it's capable of. And then folks love working with peer navigators. One of this participant's most memorable experience was the conversations that they had, as Wanda described. The weekly exercises and the homework was really helpful for me. It was a way for folks to stay engaged in what's happening, not only in the sessions, but building that capacity to stay in care. And so we have a couple of videos that we'd like to share, some testimonials from folks who have participated in the study. This one. I'll show a couple. Do you have any questions?
I'm in total agreement to anything that's going to enhance the quality of life for African American women living with HIV. So I'm in agreement.
Shall we get started?
Yes, ma'am.
All right. Can you say a little bit about your role and how you became familiar with the Link Positively study?
I became involved through Dr. Jamila Stockman and the Community Advisory Board for Cure for AIDS Research through UCSD. That was roughly, I'd say, 6 years ago, 5 or 6 years ago. And
if I may, I'm gonna play one that's a little bit more impactful. Can you talk a little bit about how you became familiar with the Link Positively study? This one.
Placing myself in the right place at the right time. Being active in finding different ways to be able to improve on myself and make myself healthier overall, like in a all health kind of way. I've signed up to be a participant in quite a few studies, so I'd like to try to keep my name as a reference when people are starting new studies as someone who may be interested. So I looked through the list at UCSD under their research categories, and I happened to come across one for the Link Positivity, and it just sounded like something that would be really useful and beneficial to me, just physically, mentally, spiritually, just all around in my healthcare. So I reached out and I got reached back too.
Thank you. Can you best describe your most memorable experience with the Link Positively study?
My most memorable?
Yes.
Honestly, what always stands out the most is that one-on-one time we get with our mentors who mentor us through it. It's such a bonding experience because you get to genuinely have conversations with someone else who understands you and what you're going through. So you don't feel like you're talking to someone who just might not quite get it or something like that. Like, no, you're right where you feel like you're looking in the mirror with yourself. Like your comfort zone is opened up exponentially during that process.
Hey, thank you for that. So, can you talk about why you think projects like Blink Positively might be beneficial to support Black women with getting in care or staying engaged in their care?
Honestly, it gives you that first breakthrough past stigma. Like that for me, that was one of my biggest things is I always felt like no matter what I wanted to do that was revolved around HIV care services or anything else, that there would be a stigma there. You know, for me being a lighter woman, you know, it's one of those things where I, you know, kind of grew up with the you want to be, you trying to be, and all these kinds of things. So just being able to break through that barrier. And when I did, it was just love and positivity and encouragement and all of that. Like for me, it was the first, yeah, like that first, I can't think of the word I'm looking for, empowerment that some women need in order to start navigating other things that can help you with your health care.
Okay, thank you for that.
Gives you the confidence. There it is. I knew I'd find it.
The confidence, okay. What would you say to Black women who may be thinking about participating in HIV research?
I would say do it. It's one of the best things you could do for yourself. And I understand the fear that, you know, this isn't going to be right. They're not really have good intentions for me, these kinds of things. But really just do your research, talk to someone, you know, talk to the person who's running it, who's, you know, overseeing the study, and get their perspective and see if there's something there that you can connect with. Because I almost can guarantee you that if it's anything like Link Positively and what I've been doing, you're gonna feel like you're right where you need to be.
Right on. Thank you. So my second to last question is, in thinking about future efforts to reach Black women, how can we do this better? What barriers do we need to address?
You know, it really is around medical mistrust. I honestly think that's the biggest hurdle. And as long as we can keep enough women, you know, enough women of color out there being a strong, positive, inviting voice to just give women a little bit of encouragement and a little bit of hope that, you know, this is something they would really want to do. You know, it's going to be through advocating. It's going to be through peer navigating. It's going to be through places like that that are good, I think would open up access to these, research studies and things more to women. Because once they've kind of tiptoed into some kind of healthcare setting, whether it's medical, mental, whatever, if there's someone there who would be able to explain what it is and what the goal is and what that is, what that would mean for women in their own life, I don't see how they would be able to be like, nah, that's not for me. I don't see that. I'd be like, if you're anything like me, you're gonna be like, sign me up. That's what I need right there. Boom.
Thank you for sharing your thoughts. My last question, would you like to share anything else to people in earshot?
When it comes to research studies for Black women, whether when it comes to research studies for women who are in need of HIV services and care, don't cut yourself short by letting fear guide you to not do something for you. Show up for you, because when you do, these studies, they show up for you a lot more than you would think. You're not just a data point on a spreadsheet. There's people there that really, really genuinely care. and connect with you and support you and encourage you to just get yourself to be the best version of you. So don't cut yourself short.
All right. Thank you so much. With that, we'll end the session, y'all. Thank you for coming on behalf of our study team. I hope you enjoy the rest of the conference.